So our next speaker is Dr. Elisha Wachman. Dr. Wachman is an associate professor of pediatrics and an attending neonatologist here in our neonatal ICU. And I've known Dr. Wachman for a long time, and she has become an international expert on neonatal opiate withdrawal syndrome. And she's going to speak with us today about her work leading this effort here at BMC, which I would point out was very much shaped by the patients that she was treating, I'm sure. So Elisha also is the new lead, co-lead of the CTSI pilot grant program, along with Andy Henderson in the Department of Medicine. So I'm delighted to invite Elisha up to make her presentation. Thank you, Dr. Wachman.
All right, here we are. Thank you so much. So it's my pleasure to be here today. I'm going to be co-presenting today with Kelly Wingfield, who I will introduce a little bit later. And we are just thrilled to be here with you today to talk about our work. We have no disclosures. So what we're hoping to do in 15 minutes or less is to take you through this translational cycle. And so how we took some of the unanswered questions that I had in caring for infants with neonatal opiate withdrawal syndrome to really create this innovative animal model that has really accelerated the path of our research and taken it back to the bedside. And I'm going to talk about throughout how we were really able to engage this population in research. So even though I think about this all day long, I realize that many of you don't. So just a bit of background, like what is neonatal opiate withdrawal syndrome, which I'm going to refer to as NOWS. So if there's chronic in utero opiate exposure, after the infant is delivered, the infant can undergo withdrawal due to the sudden cessation of the exposure to opiates. And this can typically present in the first week with a number of signs and symptoms, most notably some central nervous system disturbances, things like irritability, high-pitched crying, as well as feeding difficulties, autonomic respiratory signs as well. Here in Massachusetts, NOWS impacts 20 per 1,000 live births. About 5% of all the infants born here at BMC, and is associated with long hospitalizations for affected infants, anywhere typically from 2 to 3 weeks in the hospital. And I think one of the things I discovered early on in doing my training here at BMC and taking care of these babies is that there is a lot of variability. And so if you look here, it's really difficult to predict. About half of infants will have withdrawal that's severe enough that it requires some sort of pharmacologic intervention. And there's a subset of infants that really have a difficult course, sometimes needing 2 or more medications, and sometimes with hospitalizations over a month. And it's really hard to predict. And so all infants we have to monitor in the hospital for about a week. The other challenging thing I have learned is there's no one universally accepted standardized approach to the way that we assess and treat these babies. So I've spent a lot of my career trying to figure out, what are the factors that are associated with differences in NOWS severity. And so starting with what are the factors during pregnancy that can influence how severe the infant's withdrawal is. So one is, which opiate was the infant exposed to? Was it methadone? Was it buprenorphine? Was it non-prescribed fentanyl? Can influence the severity of withdrawal. The other issue that we see commonly is that infants are more commonly than not co-exposed to other substances, most notably nicotine, other non-prescribed drugs, psychiatric medications, which can alter the severity of the infant's withdrawal. And so much of the research that we do here at BMC really focuses on these modifiable factors in the mother. And so we have a research program that focuses on looking at different medication treatments in the pregnancy, for instance, altering the type of buprenorphine they receive. We've been studying extended release naltrexone versus buprenorphine during pregnancy. And some of these studies are really intense. I mean, we're talking about weekly study visits, sometimes for 1.5 years. And so I think the key to all of this is that, these studies all align with their personal care goals. Like, it's an incredibly motivating time during pregnancy to end their to really remain in recovery. And so how can we align our research with those personal care goals? So everything that we do is in coordination with their routine care here at BMC. And this is an incredibly difficult population to engage. I think we heard this morning all of the challenges which we see with housing, with transportations, with psychiatric comorbidities. Complicated now is that you have a pregnant person and a parenting person who now we have the Department of Children and Families involved, and trying to retain this population for a year and a half, 2.5 years in a research study can prove challenging. So how do we do it? So there they are right there, my team. So I think really what it is again, I think the key here is that research is part of the mission of the clinical team. And so I partner with Dr. Kelly Saya, who is the head of the Project Respect Pregnancy Clinic here. And this partnership with the clinical team, it couldn't happen without this. And I think too, the team approach. And so they don't know it, my coordinator's right there, that they are secretly getting their social work degrees in this job as a research coordinator, because it's more than just a job, right? You're working with these patients and getting them and meeting them where they are, which is absolutely key. It's not just, by the books, but, working with this population, takes a bit more to ensure sort of that trust and engagement. Moving on to the baby, there's many factors that we've identified in the baby that are associated with differences in outcomes. One is infant sex. So male infants tend to have more severe withdrawal than females. The other thing, which I've spent many, many years studying, is hospital care model. So whether you care for infants in the room with the parent, say in a non-intensive care setting, versus a NICU, huge impact on outcomes. The other factor is what tool you use to assess the babies. There's function-based assessments versus numeric scores. And, these, just to give you a sense, like how much does this matter? Like 50%. You can drop the length of treatment and length of stay, in half by simply putting them in the room with their parent. Not rocket science to realize this, but a lot of these factors, which I think the problem is, it's hard to measure them. Right, hard to measure like the percent of time like a parent is present, but can have a tremendous impact on the severity of the withdrawal. So as a NOWS researcher, this makes my life very, very difficult. I was fortunate to be part of the study, which I'm sure Dr. Feldman remembers this one, the double-blinded, double dummy study of controlled substances in newborns, dosed every 4 hours. I'll tell you, there's very few studies. The largest study to date was 118 infants across 8 sites. Took us about 6 years to complete. It's very hard work to do, as you would imagine, sample size. And then how do you deal with all this variability in exposures and hospital care practices across the different sites? How do you deal with not measuring these non-pharmacologic factors? And then what happens after discharge if there's a change in custody? So this makes this really hard to kind of move forward in any sort of fast way to make decisions. And so, and then the question that has always become, there's this unknown factor that even if we know all these variables, we still can't predict who's going to end up on medication and who's not, which led us to think about genetics. Could there be differences on a genetic level in the way that the infants are responding to withdrawal? There must be, we know this is true in adults. And so much of the work that I've done has focused on this. And again, this early work was funded by a BU CTSI pilot grant in collecting saliva samples and trying to look at genetic variants. And I've highlighted here kind of some candidate genes. So could it be something with the opiate receptor, such as the kappa opiate receptor, and the way that the infants are responding, the way that they're metabolizing the opiates, or stress response genes, some of these neurotransmitter genes, could these be responsible? I think I kind of hit a roadblock here because in order to get the sample sizes we needed, this just wasn't possible. It would take me a decade to figure this out. The other problem that we had, again, the multiple exposures, and how do you deal with that? And we were using saliva. I'm like, does that really matter? Is it like what's actually happening, and the level of like the brain tissue, does this actually matter? And so from all of these questions was born this wonderful collaboration with the Cameron Bryant Lab. This was back in, I believe, 2016. So it's my pleasure to introduce Kelly Wingfield, who is a PhD candidate in the Department of Pharmacology here at the medical school, who's going to take us through the animal model that's been created.
Great, thank you. So in our mouse model of NOWS, we inject pups twice daily with either morphine or saline. And it's important to note that this time period is roughly analogous to the third trimester of human pregnancy, and that's from postnatal day 1 or P1 until P15. And during spontaneous withdrawal on P7 and P14, we test pups for withdrawal-like behaviors such as excessive crying and hyperirritability by recording ultrasonic vocalizations in isolation, followed by pain sensitivity testing using the hot plate latency assay. And on P16, we collect brain tissue for transcriptomic analysis, so we can look at differentially expressed genes during withdrawal. And this model provides many advantages. For one, we can easily obtain a large sample size and have access to brain tissue, and we can control for multiple environmental factors such as the drug dose, maternal care, the type of substance exposure, and multiple substance exposure. But the data that I'll be focusing on today focuses on how we can use ultrasonic vocalizations or USV emission as a quantitative tool to study complex traits such as hyperirritability and excessive crying in mice, which are common features of NOWS in infants observed in the clinic. Excuse me, that was my slide for that. Okay, so USVs in mouse pups are exclusively emitted in isolation, and they essentially serve as a distress signal to communicate negative internal states and promote maternal attention. So in this case, during spontaneous withdrawal on P14, you can see here in orange, our morphine-exposed pups vocalize significantly more than pups treated with saline. Thus, we can use USV emission as a tool to study that excessive crying trait in mice that is observed in human infants. We also know that sex contributes to variability in NOWS severity, so we decided to break the data down by sex. And here you can see that morphine-exposed females in orange actually vocalize more than morphine-exposed males in purple, and these saline controls. So mouse USVs can be classified into different syllables based on differences in their spectrotemporal properties, so changes in frequency over time. But despite knowing that these different syllables exist, their connection or their meaning in terms of internal states still remains unknown. But we found during withdrawal on P14, we saw a specific and a significant increase in the proportion of this complex 3-syllable emitted, which suggests to us that this complex 3-syllable may be a potential and novel method or quantitative method to study negative internal states such as hyperirritability in mice, which is observed in human infants. We also know that genetics plays a huge role in contributing to variability in NOWS severity. So we collected brainstem tissue to study or to look at differentially expressed genes during withdrawal. So on this figure here, our x-axis is log2 fold change, which is our positive number is going to be upregulation, and our y-axis is significance, and the dotted lines are what we set to be statistically significant. And the labeled genes are candidate genes previously identified to be associated with withdrawal severity. And what's interesting, you can see, I've noted, we see an upregulation of the dopamine transporter, SLC6A3, which we saw earlier to be a potential gene associated with NOWS severity. And this effect was completely driven by females, so another sex-specific effect we see. But we're particularly interested in this upregulation of the kappa opioid receptor, given its role in mediating negative internal states such as anxiety, anhedonia, and irritability during withdrawal. And since we study these states in mice using that complex 3 emission as a quantitative tool, we wanted to see if we could target kappa opioid receptors as a potential way to reduce withdrawal symptom severity in mice, as represented by increase in complex 3 emission. So to do this, we administered a selective kappa opioid receptor antagonist called norbNI and to block kappa activation during withdrawal. And again, we see another sex-specific effect here on the top left. Our morphine females that were treated with norbNI in purple emit significantly less complex 3 syllables than our morphine females treated with saline. On the left, that's orange, and on the top right, that's yellow. And what's interesting is that we didn't see this effect in males. So this data suggested to us that the kappa system may be more active or more involved in mediating this complex 3 emission in females during withdrawal than males. So we see many similarities in our data as we do in human infants in the clinic. For one, we observe sex differences across several withdrawal phenotypes. In our case, we see females showing more severe withdrawal symptoms, withdrawal associated traits. We also see similar differentially expressed genes and withdrawal-like phenotypes such as hyperirritability and excessive crying. But taken together, this mouse model really allows us to investigate biological mechanisms contributing to complex traits such as hyperirritability, excessive crying, and also differentially expressed genes that can be difficult to study in human infants in the clinic.
All right, thank you, Kelly. So how can this inform our human work? So I'll tell you, I have very much shifted our approach over the years. I think I was asking the wrong question for many years and trying to predict now severity, where the answer was very clear that all I needed to do was put them in the room with their mom and they were going to do just fine. But the real question that I wanted to answer, and I think all of us, what we really care about is what happens long term, right? What is the effect of in utero opiate exposure on the growth of the fetus, on brain development and long-term outcomes. So I think our research, partly informed by this work, in the mouse model has really shifted to that new focus. And so one is we realized that we did have a tissue available to us sitting in a bucket on labor and delivery in the fridge, the placenta. And so this is a tissue in which we can actually look at these same, questions with gene expression and DNA methylation on a genome-wide level in a way that's very non-invasive. And so we partnered with, again, here's my wonderful collaborator, Dr. Taglauer from the Department of Pediatrics, as well as Dr. Zhang from the Department of Psychiatry and Dr. Bryant. And we have partnered to really focus on, again, looking at placental tissue, looking at gene expression, and really now asking the question, what is the impact on brain development and long-term outcomes, which is really, what we care about in terms of improving the outcomes for these families. So we've enrolled over 400 dyads to date since starting this study here at BMC. Again, the focus now is to really look at the associations of these changes with brain development, again, using sort of non-invasive approaches, which are patient-centered. So I hope that I have taken you through this cycle and sort of shared with you how, we've been able to partner kind of this human cohort with the mouse cohort to kind of move this research along. And I hope that there's time for a lot of continued collaborations moving forward. We want to thank all of the members of both of our labs and our funding, and Kelly and I are happy to take questions.
That was an excellent presentation. I have two questions. One for Kelly, what was the rationale of the dose that was used of morphine? No? And the second question is there any plan after delivery for breastfeeding, with fast metabolizers, slow metabolizers, for the mother?
Right. So the rationale for choosing drug dosing was based on previous studies. So this model was established by previous groups. So we decided to stick with that and use the same dose. It's 10 mg per kg subcutaneous, in case you missed it. And then for breastfeeding, so the pups are injected with morphine or saline twice daily, so they don't receive morphine from the mother. So we decided to do twice daily injections in the pups to control for morphine dosing, because when they're in utero, some pups can receive more morphine than others. Does that answer your question in regards to breastfeeding?
How equivalent is that dose to human exposure?
Oh, I'm not sure. I'm sorry.
I think I can just speak to the backstory of working with Cameron for all those years. And there was many models that we went through of like implanting the pregnant dam with methadone and morphine. And I think ultimately thinking about the third trimester is like, this is the key exposure when you're thinking about neonatal opioid withdrawal. So exactly what they're doing now is like really exposing the, the neonatal pup to the morphine. Equivalent dosing for neonates, I don't know that matters so much. There's not a dose specific response to say morphine and buprenorphine in human infants. It's not dose, it's more like the timing of the exposure, but not so much the milligram amount that is associated with differences in withdrawal. So I don't know that I would expect to see huge differences with the milligram that's used.
I just have a quick question. At the beginning, did you say 2% of infants in Massachusetts? Wow, that's a lot of kids.
Yeah, so New England is sort of second to, I think the highest areas in the country are sort of the Kentucky, West Virginia area, where it's as high as like 4 or 5% of the population. New England's kind of like second up there, and 2 per 1,000 live births. Yeah. 20 per 1,000, sorry. Okay.